Kia ora koutou.
Morning all.
No mai kite wananga whakamana kai turoro. Welcome to our Blood Cancer Patient Forum. I'm Matt, and this is Helen from LBC. Now, we would have loved to be standing in front of all of you at the Ridges in Christchurch, but darn COVID had to rear its head again. So now we are sitting in front of a large screen in our Christchurch Center. Thanks for joining us, and especially to our Auckland people still in lockdown level 4, kia kaha to you as well. Now, we would love to share a karakia with you, and this is one that was actually gifted to our organization for this event earlier in the year. So I'll just read that for you all. Turo paria, paria I ronga, paria I raro, unohia ra e tane, unohia e rongo, turo ora, to mai te mori tu, te mori ora, tu tawa I roto, tu tawa I waho, homie, huie tagie. In English, ward off that from above, fend off that from below, extract otane, remove orango, health and vitality, come forth from within, from the environment, for all who unite as one.
Thanks, Matt. We also got gifted a karakia, which we were going to sing to you all, the support services team. So we won't be doing that, but you can, if you turn to page 31 of your handbook, you will be able to read that. So I'm just going to talk to you today about how today will run. We hope that you find our program very interesting and informative. So how to access these talks, you will notice that there are 5 different streams, and they're all named with the room numbers from, or the room names from the Ridges. So currently we're in what we're called Savoy West. And at first we'll be continuing on the same link, and we'll have the keynote speakers, which are Dr. Rob Weinkove and Dr. Myra Ruka. And then you'll be able to join the session of your choice after the morning tea break. You'll see there'll be a couple of concurrent sessions, and then there'll be lunch break, 2 more concurrent sessions, and then we'll all come together at 4 o'clock for the closing talk with Dr. Graham Kidd. So you just go to the room and the talk that you want to listen to, and just click on that and you'll go into that room. You'll also notice on the program that they're what we call meeting hubs. So the idea of this is, if you can't find a session that appeals to you, or maybe you just want to break from all the education stuff, just head into a meeting hub. They'll be facilitated by LBC staff, and you might get to talk to some other people within that meeting hub. So these will happen at 10:30, 11:30 and 1:30. Again, just click on the session on your online program to access these. Something also to remember, if you've got sessions that are conflicting and you want to listen to more than one, all these talks except the Pharmac one will be recorded. So these will be sent out at different times on our Facebook and YouTube channels. So you can watch these at a later date. This patient forum, it starts off the month of September, which is World Blood Cancer Awareness Month. So there's going to be plenty of information and blood cancer awareness activities on our digital channels over the entire month of September. And those of you from Auckland would have seen the Sky Tower light up red on the 1st of September, just to denote Blood Cancer Awareness Month. So thanks to the Sky Tower, they're great supporters of LBC. And also a shout out to Joe and Maggie, who are our marketing and digital gurus based up in Auckland, who have been coordinating this campaign. And yeah, just a shame they can't be with us today in Christchurch. So if you do have any issues, I mean, we can't solve all your internet ones, but if you have issues with accessing some of the talks, then just text Embarker. She's sitting up there in Auckland. She's our operations manager, and her number is 027, we'll pop it up on the screen, 027 823 1223. Fabulous. Okay, Matt.
Cool. And thanks, Helen, for breaking that down. Now, for those of you that who are registered or who did register to attend in person, you would have received a goodie box, which I'm sure you are enjoying. Inside, there was a postcard sent to you so that you can fill these out and jot some words of advice for future patients. Or if you have downloaded our app, you can use the app to message us today with your words. It would be so great. And in fact, for any of you that send this in on a message or the postcard, you would be in to win a draw. So a draw to win one of 2 gift baskets by sending in your postcard or a message. So another housekeeping thing to do with watching these webinars today, just if you could use the Q&A button to ask your questions instead of the chat box when you are in the sessions today, much appreciated. Lastly, I would like to acknowledge our LBC staff for putting in the hard yards and bringing this to fruition. And one especially big mention to Sheldon from our admin team, who provided our team with superb and phenomenal support to actually make this happen. So thanks, Sheldon, on that one. Now at this time, we would like to simply roll along with our intro and get into these the keynote speakers. So the first one will be from Dr. Rob Weinkove. So who is Dr. Rob Weinkove? Well, he's a consultant, a hematologist, and clinical director for the Malgan Institute in Wellington. He studied medicine at the University of Cambridge and King's College, London, and specialized in hematology at Guy's and St. Thomas's Hospital in London. He has a PhD from the University of Otago, Wellington. Rob's current research interests include tumor immunotherapy using innate-like T cells and hematology supportive care. So I'm going to hand it over to Rob and get the video up and running here. And his talk is Advances in Hematology, Past, Present, and Future. So just bear with me on the technical side here. Hey, welcome, Rob.
Thank you very much. And thanks, LBC, for the opportunity to speak today. And just, we're all thinking of our colleagues, patients, friends in Auckland, and everything that you guys are going through at the moment. So kia kaha. And, we're thinking of you guys, and thanks for joining those of you who are coming, dialing in from there. So I'm going to try and share this screen with you. And I've been asked to give a presentation today about advances in hematology, past, present, and future. And it's quite a broad topic, and I've only got 20 minutes or so. So I'm going to try and just give a broad spectrum of some of the concepts of the way I think things are moving in the future, and the great successes we've seen so far, and where we've really still got work to do. So I had a look back, and rather than going back into the dim history of blood cancer therapies, I sort of look back at when I first started training in hematology, which was 2004. And that was the time when our mobile phones looked like the Nokia that you can see on the far left. And when we look at what's happened in terms of 10-year survival of blood cancers from people who are 10 years after diagnosis in 2004 compared to people who are 10 years after diagnosis 10 years later in 2014, you can see that in that 10-year span, which is a bit of a way ago now, we came on a huge way. And these figures just show 10-year survival of a number of hematologic malignancies. And you can see that by and large, they improved by around about 10%. And this is great news. And this is perhaps just 10 years of progress, about 10 years back from now. And it just shows how far we've come along. And there's a number of different avenues and reasons that this has happened. Part of it's been immunotherapies like rituximab. Part of it's been kinase inhibitors for chronic myeloid leukemia. A lot of it's been new treatments for myeloma. And as I'll talk about later, a lot of it's been supportive care. But clearly, we've still got a huge amount of work to do. There are still, even 6 or 7 years ago, malignancies where our 10-year survival rates were below 50%, and we had to do a lot better. And we already are beginning to do better, and we've got a lot further to come. And this talk's going to perhaps give some scope of where I think those advances are most likely to come from. So I was sort of thinking about this in a very broad sense. And the first question is, are these advances going to come from conventional cytotoxic chemotherapy? And I think it's not terribly contentious to say that the answer to that is probably no. And the reason that I'm reasonably confident of saying that is our chemotherapies have remained roughly similar to what they were certainly when I first started training. So the conventional cytotoxic chemotherapies, the backbone of our chemo treatment for acute myeloid leukemia, those things haven't really changed for about 30 or 40 years. Our backbone of chemotherapy for aggressive lymphomas, those elements haven't changed a great deal. And although we got better at using those treatments, as I'll talk about in a bit later, and managing side effects from those treatments, it's not really the chemotherapy agents themselves that have come along a huge amount. That's not to say we won't see some improvements, but I don't think those are going to lead to the real major improvements in survival in the next decade. What I think we are getting better at and will continue to get better at doing is selecting the right treatment for individual patients and knowing when to stop that treatment and knowing when to intensify that treatment. And I'll talk about that in a moment. We've also seen a lot of these targeted therapies, and by that I'm referring to normally tablet-based treatments that interfere with signaling pathways inside leukemia or lymphoma or myeloma cells. And the poster child for that, as I'll talk about in a moment, is chronic myeloid leukemia, but that's now coming into other malignancies, and I think we're likely to see a lot more of that in the next decade as well. I'll talk a bit about immunotherapies. I'll talk a bit about gene therapies, which are already coming. We're already starting to use those here in clinical trials, and I think they're going to be one of the factors that really takes us forward in the coming decade. And I don't want to forget, because it's a bit of an interest of mine, supportive care, because we can do all we like with all these treatments, but if we treat somebody's malignancy and then people then get very sick with diseases, and of course COVID-19 has thrown that into stark relief, then there's no point in doing what we're doing. So this remains really important. And in order to reconcile all that, to put all that together, to get better at using these drugs, we're going to need new clinical trial designs so we can make our advances more rapidly and get the right treatments for patients into them faster. So I want to talk a bit about treatment selection, and it's fair to say that we've now got much better classification and prognostic tests. When I first started training in hematology, there were 18 subtypes of acute myeloid leukemia. Now there are 26, and with modern gene sequencing techniques, one example of some genes commonly mutated in acute myeloid leukemia is on the top right. We can now segment these to the nth degree. You know, people are arguing that acute myeloid leukemia is hundreds of different conditions. Now that in itself, that complexity isn't necessarily helpful for us as individuals, but it does mean that we can pick out groups of people who are most likely to respond to certain types of treatment. So that's where that really becomes relevant. So we've definitely got better classification, better prognostic tests. Some of you, if you've got myeloproliferative disorders, will know that we're doing new molecular tests that we weren't doing 10 or 15 years ago, and we're better able to decide who needs medicines to lower the platelet count, for example. So these things are a reality, and they're going to continue to come along. Something that we're beginning to do in some conditions is testing for disease resistance mutations, and that gives us a feeling for whether somebody's condition is likely to respond well to chemotherapy or not right from the outset, and then pick the relevant treatment right from the beginning. We're just on the cusp of being able to do that with pharmac-funded therapies for chronic lymphocytic leukemia at the moment, and I think that'll come for more conditions in the future. We can monitor residual leukemia or lymphoma, often with blood tests, so we can see if our treatments are working very well quite early on in the course of the condition. And similarly, we can use scans for lymphomas, perhaps scanning people after just 2 or 3 rounds of treatment using PET scans. And by that, we can work out who's responding well to the treatment and in whom we might be able to abbreviate or reduce the intensity of chemotherapy without compromising outcomes. But we might also be able to work out who is not likely to respond as well to our first line of treatment and who might need more intensive treatments or alternative treatments. And this is a reality. We are capable of doing this. The things that are holding us back are the access to PET scans, the funding for PET scans, and coordination nationally is going to be really important to bring this into our routine treatment going forwards. So I want to talk briefly about new targeted therapies, and if your screen allows, depending on where I'm sitting on the screen, I've got a little meme there that says, "I used to care, but I take a pill for that now." This is perhaps not meant to refer to these drugs, but almost it feels that way with chronic myeloid leukemia, where the treatment advance has been so impressive that we're at a point with chronic myeloid leukemia that for most people who tolerate and respond well early on to these new tablet medications, the disease is thought to have a minimal or no impact on life expectancy. And this is fantastic. We're turning this from a condition that had a major impact on life expectancy to something that's now a chronic illness that you might live with, take a tablet for, but actually be well indefinitely. And that's a really great outcome for that condition. We're getting there with chronic lymphocytic leukemia. We have some issues around the funding of these treatments, and it certainly appears to be the case that these new tablet medications probably have to be used in combination to actually stand a good chance of really getting rid of the disease to a very great extent. But I would say that in overseas countries, it's quite common for people to be managed entirely with non-chemotherapy based treatments for chronic lymphocytic leukemia, and hopefully we'll be in that position in the coming, certainly within the coming decade, and hopefully sooner than that. And then acute myeloid leukemia, the illness where we've historically struggled most, we're getting to the point now where there are drugs that certainly can benefit being added to early intensive chemotherapy with improved outcomes for some patients. We don't have those funded and routinely available yet, but we can access them sometimes in clinical trials. And then in older adults, it's certainly the case that some of these newer tablet-based or injected targeted treatments can work very well and give an option for a non-intensive outpatient-based treatment, which is probably the approach that we have to take with our older adults. And I'll talk more to that in a moment. Immunotherapies tend to hit the headlines a lot. Of course, I'm very interested in them, and they are fascinating. And in a way, what's worked well with these is the designer element to them, in that it's very possible to rationally design these types of treatment and to assess different types of treatment accordingly. So we've been using antibody treatments for quite a long time to treat blood cancers. And the first of those was rituximab. And we've been using that really for nearly 20 years now, with great results in B-cell lymphomas, and we will continue to do so. We got other drug treatments, other monoclonal antibodies coming along, although we got relatively few other ones funded at the moment. Another type of treatment that is available in selected situations are antibody drug conjugates. On the top right of the screen, I've drawn an antibody in orange there. Basically, they latch onto the malignant cells, onto a target of choice, and they label them for destruction by our immune cells. Another way of using those treatments is to basically attach on chemotherapy drugs to the antibody and use the antibody as a way of delivering the chemo drugs directly to the cancer cell, and therefore targeting the chemotherapy treatment much more accurately to the tumors that you want to eradicate. So those are a treatment that we can use, we do occasionally use. We get special funding for occasional patients, so we use them in clinical trials. They're not so routine right now. There's a couple of other treatments which I won't talk about in too much detail, just for the broad nature of this talk, but there's other ways of targeting other immune cells directly to cancer cells. One is through special kinds of antibodies that link two antibodies together and target different types of immune cells that way. These are being used in clinical trials in this country. And it's also possible to gene modify immune cells. On the bottom right there is a machine that we're just beginning to use at our own center to gene modify patients' immune cells to redirect patients' own immune cells against their own malignancy. That's called chimeric antigen receptor T-cell therapy. And I think we'll hear a lot more of that in the future. It's becoming a standard of care in some countries elsewhere. And we're trying to bring that here through clinical trials, and we are indeed doing a trial of that at the moment. So just in the sake of breaking up the PowerPoint slides, this is a short video of some T cells. These are immune cells in green, ganging up on a tumor cell, which is there in red. And you can see that as the video loops round, they're migrating towards the tumor cell, forming these, we call them synapses, these links against the tumor cell, and they secrete their cytotoxic activity. And as the tumor cell dies, it flashes bright red, which is called apoptosis. It's the process of the tumor cell dying off. And so they're fascinating cells. They are but one way that I think cancer therapy is going to advance in the coming decade. This type of treatment won't necessarily work for everybody, but I think they will work for some people. I do want to talk about gene therapies. Now, I think we have to get our head around these gene therapies because I think they are coming. And like every new treatment, often there's a lot of promise and a lot of discussion. Scientists, we tend to be very guilty of saying, oh, this is 5 years away, but things end up being 10 or 20 years away. But we really are getting to the point where gene therapies are on the cusp of entering the mainstream. I think it's fair to say that now. And CAR T cells are one of those types of treatment where we genetically modify patients' own immune cells and give them back to them. There, all the gene modification is done in the machine, like I showed you earlier, or in the laboratory, rather than inside the patient themselves. And that, I would just point out, the gene modification is restricted only to those particular immune cells. So the person themselves doesn't change. We are beginning to see great data now for gene therapies for some hereditary blood disorders, and in the field of haematology, haemophilia is one of those conditions where it does appear to be possible to provide the missing gene that allows some people to make a clotting factor. For this type of treatment, usually a viral vector is given to the patients intravenously, and it goes in and modifies some of the cells in their liver so they can start producing this clotting factor again. And we have seen trials where people have now become free of needing clotting factors and free of bleeding problems for many years after this type of treatment. Clearly, there are still significant safety issues, and of course, then we'll come across funding issues later about how we deal with that treatment. And I just want to mention, because we perhaps don't recognize how much of a difference this might make, is what's called RNA interference. I'm not going to go into that in detail, but basically it's a way of giving injectable treatments that interfere with the way cells make a particular protein. And the fascinating thing about that is it's very easy to target pretty much any protein that you want, any of the genes in the human genome. And it's not a permanent gene modification, it's temporary. Now, the thing that's held back that type of treatment until now has been the RNA modification, usually required giving things through the veins every day or via a continuous infusion. But we're now at the point where this can be done with injections once every 6 months. And recently, for example, in the UK, one of these types of treatment has just been approved for certain types of high cholesterol, and it's an injection once every 6 months. So I think we will see this RNA interference emerging. It's very easy to design new drugs with that approach and make them very, very specific at targeting just the proteins that you want to target. I want to speak briefly to supportive care, and I think it's easy to get blinded by all these new fantastic treatments and miss out what we have to do, which is we have to make sure we're not making patients sicker with these new treatments. On the bottom right is a type of curve which in medicine we call a Kaplan-Meier survival curve, and it basically shows the survival of people with acute myeloid leukemia over decades. And what happens is, with this curve, the proportion of people that are still alive a certain number of months after their diagnosis is shown. And what you can see in the blue line is, if you look back at the 1970s, if you were diagnosed as an adult, a younger adult even, with acute myeloid leukemia, and this is at the MD Anderson Cancer Center, one of the very large, very famous hematology treatment centers worldwide, you can see that unfortunately, the outcome was really, truly quite dismal for people with acute myeloid leukemia back in the 1970s. And as we've moved through the decades, the survival has progressively improved over that time. And this is to a large extent due to improvements in treatment, improvements in bone marrow transplantation particularly. But I want to focus perhaps on this early point, this first 3 months. And if you zoom in there, what you can see is quite stark, that in the 1970s, if you were a younger adult with acute myeloid leukemia, about a third of patients died within that first 3 months after being diagnosed. And this wasn't to a large part due to the chemotherapy, because even back in 1973, they were using the current chemotherapy backbone that we use now. Now that figure is just a few percent. And the real benefits there are our supportive care. And we've got a lot better at preventing infections through good antifungal medications, diagnosing infections, and the basic things, spotting the fever, getting people started quickly on the antibiotics. Some of this just requires those basic fundamental policies and procedures, so that if somebody gets an infection, they get straight on the right antibiotic, get straight to intensive care if they need that type of care, and get managed well. And we're much, much better at that. We need to continue to focus on that, because there are huge benefits to gain there, I think, as we get better and better at supportive care. I'll talk this afternoon, by the way, about COVID-19. Later this morning. Not to overlook transfusion. We got a lot better at giving transfusions. Our blood transfusions are much safer than they used to be. We're much better at knowing when to use blood transfusions, and we still have work to do in that. With acute myeloid leukemia, we're getting much better at managing clotting and bleeding problems, and this is very important, and I think we'll continue to see benefits there. And then with all of this, even though there may not be huge advances in the chemotherapy drugs themselves, we are getting better at delivering those agents and preventing toxicities. We've got much better anti-nausea medications. We're better, although by no means perfect, at knowing how to preserve people's fertility before and after cancer therapy. So there's a lot we can do here, and the supportive care questions will change as our treatments change. They'll be equally important, but they'll be different questions. Now, this chap is someone called William Osler, and medical students will know this person because something called Osler's nodes are named after him, which are little spots that we get during certain infections. And he was quoted when I qualified for medical school by the dean, who said, "Half of what we taught you is wrong, and we can't tell you which half it is." And what he meant by that is we have to really recognize that medicine is a story of continuous improvement, and we're going to have to keep getting better at learning how to use these new treatments. There's no use in just bringing those in without properly checking that they work and that they're not having undue adverse effects. And that's going to require clinical trials. And the traditional way that we've run clinical trials is that we might take groups of patients, and perhaps we will or perhaps we won't have a clinical trial available for that group of people. That clinical trial might be open at some centres in New Zealand, but not all centres. And those who are eligible for a trial go into a trial to test a treatment, and then we see what works and what doesn't work. It's not very efficient. Each individual clinical trial takes a lot of effort by the trials unit, by the clinicians to set up. It takes a lot of effort for the ethics committees and so on to supervise those. And it's very difficult to make progress rapidly, especially as we're getting much better at the number of potential treatments and avenues of treatment is expanding rapidly. And so the way we're moving forwards is something called platform trials, or one particular type of those is called an umbrella trial, in which we might take all people with a particular type of blood cancer, say acute myeloid leukemia. Everyone will be tested to see what mutations are there, and all within the umbrella of that trial, there'll be different arms for different treatments. And that gives access to treatments for almost everybody. And even if someone doesn't have a particular mutation in their disease that can be targeted with a specific new drug, there may still be other questions that can be answered, for example, about supportive care or the dosing of existing chemotherapies. And that allows us to get better much faster. And this is really the way forwards for a lot of leukemia and lymphoma trials. What's more often built into these trials is something called adaptive design. And what that means is that the less effective treatment arms are closed if they don't look like they're working well, and the most effective treatment arms are expanded. And that maximizes the number of people who are getting the most effective treatments within these studies. So we get to the answer more rapidly. And what's also important about these trials is they're flexible enough to add new treatment arms as new treatments are discovered or new subtypes of a disease are discovered. So this type of approach is going to be really important in the future. If you haven't seen it, this movie just came out this week, James and Icy. I strongly recommend it. I watched it the other night, and it's all about Icy's 100th birthday and her son James, and celebrating that. And the reason I put Icy on here is that we are seeing a paradigm shift at the moment. So we are here in 2021, and what you can see is that the fraction of New Zealanders who are over 65 has been rising quite rapidly over the last few years, and the number of New Zealanders who are over 65 is going to double in the next 20 years again. So that's quite a dramatic change, and it's important because most blood cancers get more frequent as we age. What's also perhaps even more stark is that the over 85s are growing or about to grow very rapidly, and that's going to be a continued increase in over 85-year-olds. So we really need to work out how we can manage over 85-year-olds. Clearly, we're not going to use our most intensive chemotherapies in the very elderly, but that's not to say that we can't offer some useful treatments to improve people's quality of life and well-being. So the changes ahead to finish with, and nothing is constant except change, is that we're going to have inclusive trials that include older adults, non-intensive treatments, and we're going to have to get good at liaising with other clinicians about the best way to manage people if they've got multiple health problems. We're always going to struggle with limited capacity. It's not just a problem in New Zealand, it's a problem everywhere. And the solutions to that are going to be more use of outpatient treatments that let people be well and in their community. For some diseases, curative treatments are going to be the priority, particularly, for example, acute myeloid leukemia. We need to get people well and get them out again if they're younger adults and there are curative treatments available. So for those types of treatments, inpatient therapy and getting that really right is going to remain very important and very critical. For many treatments, we might need to use more nurse and GP-led care. We've got a lot of people now living a long time on these kinase inhibitors. Do they really need to see a specialist hematologist every 3 months? Perhaps they don't, and perhaps they can be safely managed in the community with the backup of the hospital system there if necessary. Drug costs are going to remain an issue for us and for everybody worldwide. We often use clinical trials to try and bridge that need. And I think we'll hear from Parmat later, but I think it's going to be really important that we pursue a strategic approach to the unmet needs. Instead of looking at one drug in isolation, say, okay, we need a Bruton kinase inhibitor. These are the drugs available. How can we work with our regulators to get at least one of those types of class funded rather than look at each drug individually? And then we're going to have to really coordinate, and we'll hear in a moment from Myra. We need to coordinate nationally. We need to make sure that everybody can get access to those PET scans that let them de-escalate their lymphoma therapy early. We need to make sure that everybody gets access to the right gene tests that allow people to get directed to the right therapy. And hopefully there are some opportunities with the new health agencies that will allow us to do that. And what I can say is that things will always change and we're always going to have to adapt, but that's part of what makes our job so interesting and privileged. And it is optimistic for the future because we have got a huge number of treatments coming. So that's all I wanted to say for now. And thank you very much for listening. And I hope that some of those elements were of interest to you. And I think we do have a good future going forwards.
Thank you so much, Rob. Really good first keynote speech, and just good to hear where the science is at. So just going to flick some things here, but I'm going to actually hand it over to you, Helen, for the next intro.
Thanks, Matt. So I'd like to welcome Dr. Myra Ruka. She is the clinical equity lead at Te Kahu, which is our cancer agency. She's a clinical hematologist and a board member of Ahu Takahu, which is the cancer leadership of Aotearoa. She is the co-chair of the clinical equity leadership at Waikato DHB on the Maori Health Committee for the Royal Australasian College of Physicians. In spare time, she's a current PhD student at the University of Auckland. She will be talking to us today about updates on the cancer agency, Te Ahu Takahu. So over to you. Let's click.
Kia ora. Lovely. Oh, I was lovely. Thank you very much, Helen. Thank you for that wonderful introduction. And kia ora koutou, katoa to everyone who's joined online, to all patients and whānau and clinicians who are sharing this session with us this morning. Nei rā te mihi, he mihi kawana kia kōrua hoki, Helen and Matt. Matt, thank you for your karakia this morning. And Rob, thank you for such a wonderful introduction to an exciting program for today. So kia ora everyone. He reo ngō raukawa me Ngāpuhi, and as Helen said, I have a role with Te Ahu Takahu as a clinical equity lead, and I'm also working my way through my PhD, and Professor Peter Broward is my primary supervisor for my PhD, with Sarah Jane Payne and Michael Jamieson looking at inequities and models of care and the multiple myeloma and cancer pathways in Aotearoa, New Zealand. I'm really passionate about hauora, sustainable living, and gardening practices and the health and well-being of our communities. So although I wear many hats, today I'm here presenting with my Te Ahu Takahu hat on, and on behalf of Diana Sarfati, our Chief Executive, it's my pleasure to share with you an update on the work that Te Ahu Takahu is doing. So first of all, I'll just get into sharing my screen, and there we go. Okay. The Zoom box won't let me click slideshow.
Okay.
Here we go. Here we go. All good. All right then. So I think the best place to start with Te Ahu Takahu and giving an update is really to start with a brief background of our name. So Te Ahu Takahu, the name embodies the essence of who we are as an organisation and how we work. And so pictured here is Professor Diana Sarfati, our Chief Executive, who's wearing a kahu or a cloak. And Te Ahu Takahu means the central thread of a cloak, and this name was given to the agency by Hei Ahuru Mōwai, the Māori Cancer Leadership. For many of us in Aotearoa, New Zealand, we can all expect to be affected by cancer to some extent at some stage in our lives, either directly or indirectly. And cancer can affect all aspects of our lives as well, our personal well-being, our participation in the community and the workplace, and in our financial stability of our whānau or families. So the name Te Ahu Takahu speaks to our role as a connecting and unifying organisation that works with the many strands relating to cancer control. So the cloak represents the whole of the system working together to provide strength, protection, and also warmth to those affected by cancer. Also, in accepting the name, the Cancer Agency upholds its commitment to honour Te Tiriti o Waitangi and its principles and intentions, also to uphold the mana and the integrity of the name and its meaning. So this taonga that Di's wearing is a really exquisite piece that's made from muka or flax fibres that are worked into a thread, then weaved into this kahu or cloak. And this taonga will sit in the Te Ahu Takahu office. So as I go through my presentation today, you'll see just how our agency is operationalising the meaning of our name. So the two threads weaving throughout the presentation today are: what is Te Ahu Takahu Cancer Control Agency and what does it do? I'll also be giving an update on the current work at Te Ahu Takahu, particularly as it relates to haematology. So where did we start? So just briefly going through some quick facts around cancer in Aotearoa, New Zealand. So cancer is the leading cause of death in Aotearoa, New Zealand. There's a doubling of cases expected in the next 2 decades with long-standing and persistent inequities. And the costs and complexity of cancer diagnoses and treatment are increasing, as Rob was alluding to. But survival is improving, but it is slower than comparable countries. This graph is taken from the Cancer Action Plan, and it shows cancer registration rates, which are age standardised rates per 100,000 for 2017. And it also illustrates the inequities between Māori and non-Māori patients with regards to cancer incidence. You'll also see here that non-Hodgkin's lymphoma is in the top 5 cancer incidents, with leukemia and myeloma also featured here in some of the common cancers in Aotearoa, New Zealand. Currently, people affected by haematological cancers, including both those that are diagnosed with the cancer, but also the people who care for them, face challenges navigating their way through a complex system of care. And so there's a real need for better access to health services that are provided in a way that is fair for all, well coordinated, and that are safe, effective, timely, and affordable. Te Ahu Takahu was established with these principles in mind. So the Cancer Agency, Te Ahu Takahu, was launched in 2019. And in these photos here, you'll see members of the Te Ahu Takahu Council, as well as Di Sarfati there on the right. So the purpose of the agency is to provide national leadership to ensure that our cancer services provide high quality and consistent cancer care. And this includes diagnosis and treatment to those affected by cancer. It also includes strengthening our approach to cancer prevention and early detection. A key purpose of Te Ahu Takahu is also to unite and lead and work collaboratively with DHBs, clinicians, cancer experts, consumers, and the Māori cancer leadership. And a critical role for the agency is to provide the New Zealand government with cancer-related policy advice. Now Te Ahu Takahu is also accountable for the progress of the Cancer Action Plan. So the Cancer Action Plan 2019 to 2029 enables Ahu Takahu to work collaboratively with the Ministry of Health, the sector, and all those affected by cancer to work to prevent cancer, improve detection, diagnosis, treatment, and care after treatment. So the four main goals of the action plan are here. So delivery of consistent and modern care, equitable cancer outcomes, fewer cancers, and better cancer survival, and better supportive and end-of-life care. The action plan informs the work program of Ahu Takahu also. So within our structure, Ahu Takahu is a standalone agency where our CE reports directly to the Minister of Health. Within our structure, the Ahu Takahu Council leadership and advisory groups reflect the weaving together of people to weave our cloak. So bringing diverse stakeholders together and promoting effective working relationships. Some of the principles that guide these relationships include prioritizing strong and accountable clinical and non-clinical leadership, prioritizing Maori leadership and partnership at all levels of the system, and to encourage consumer leadership and engagement in co-design. So the consumer reference group comprises members that have experience in haematological cancers, and the Heiahuru Mowai Cancer Leadership also provide expertise from a national Maori cancer expertise membership as well. And the clinical and advisory work groups, we have 2 of the 4 clinical advisors for Ahu Takahu are haematologists, including myself and Dr. Humphrey Pollen, and Dr. Richard Ducey and Dr. Rob Weinkove are also members of the COVID Agile Response Team. So the sharing of knowledge, skills, expertise are really necessary for the team to deliver the actions needed to improve outcomes for all people affected by cancer. And here we see a photo of Dr. Rob Weinkove taking the team through a session on immunotherapy. So the Ahu Takahu teams, this is a list of our teams. The teams are split into work streams, and these work streams are really focused on accomplishing the goals set out in the Cancer Action Plan. And each team often works in collaboration alongside each other and with the leadership and advisory groups. So here we have our Equity Director, Michelle Mackel, who is leading in the past has led quite a bit of work with regards to establishing a Mātauranga Māori framework and an equity first prioritisation framework over the work streams that are occurring within the agency. She also has quite a few team members looking into the NTA program nationally and trying to improve the facilitation of transport and accommodation support for our patients and their families. They also look at the role of telehealth and addressing inequities within the telehealth platform. And they've also been instrumental in developing an equity framework for prioritisation of work plans, of which one of the current work plans is looking at national coordination of services throughout New Zealand as we move into this new phase of the health reforms. So here we have Gabrielle Nicholson and Associate Professor Liz Dennett, who's the Clinical Director of the Treatment Quality and Standardisation team. So Te Ahu Takahu has continued the Ministry of Health Cancer QPI program, which aims to inform quality improvement for cancer diagnosis and treatment across Aotearoa, New Zealand. And this just also reflects what Rob's quote by Mr. Osler in his presentation, that medicine is a story of continuous quality improvement. And in order to know where we're going wrong or where we're doing well within a system, within cancer pathways, we must have a framework of quality improvement from which to lay on top of the work streams that are currently occurring nationally over the cancer services. So a major focus also, as well with this group, is to achieve equity of outcomes and contributing to wellness for all, particularly for Māori and Pacific peoples who currently experience poorer cancer diagnosis, access and treatment outcomes. So this photo is from a QPA program, Hui, earlier this year. So the Quality Performance Indicator program includes quite a few teams. The teams involve clinicians both in the primary and secondary sector, public health physicians, pharmacists, nurses. It's a very collaborative space. So this program will be used to inform the improvement of cancer services. And also, it will also look at the publication of the QPI results by district health boards to assess any unwarranted variation within a DHB's key performance indicators. And this will enable DHBs to compare their performance with other DHBs as well, but also to inform their ongoing continuous quality improvement process. So here we have John Fountain, who's the manager of our data monitoring and reporting team. So this team have been over quite a few projects as listed here. And really this team was set up in recognition that current cancer information is created and stored differently by a range of depending on where you're located. So depending on the local practitioners, the clinics, hospitals, and non-government providers, there's such a variability in how we are collecting and storing information about patients and the services that we deliver. So establishing one of the key goals is to establish a reliable and accurate picture across the cancer pathway for patients, and this will be by cancer type, region, or demographic group. So hopefully the goal from this work stream, as I was saying before, is to provide better information and supports to empower more accurate decision making. And this decision making isn't just for clinicians or policymakers and researchers, but also for patients. For when patients decide on a cancer pathway, what treatment or what pathway they would like to choose, which best meets their individual needs. So the data monitoring and reporting team partners with government, health sector, academia, international experts, local clinicians, pharmacists, and data analysts as well in a really coordinated way. Some of the outputs have been a national MDM guidelines, the State of the Nation Cancer Report, which was published late last year, which provided an up-to-date baseline of cancer data in Aotearoa, New Zealand. And currently, this team is working on an anti-cancer treatment project. So this is the Act Now project. And the aim of this project is to establish new systemic therapy national data collection suite, which depends on really well-informed, well-designed analytics to guide improvements in equity, clinical quality, and resource utilisation. So the Act Now project team is represented by medical oncologists, haematologists, oncology pharmacists, nursing, researchers, and equity reporting specialists. Dr. Pullen and I sit on this work group. And Dr. Pullen takes many of the questions raised within this work group back to the haematology working group to feed back into the main project. And so what does this mean for patients and whānau who are on their cancer journey? This means that there will be a national database that records when you're diagnosed, what treatment you received, and when, if you had any significant side effects, what the response to your treatment was. And no matter where you go in New Zealand, clinicians will be able to see this information. And it's just a really good way of streamlining care nationally and making sure we have a consistent approach to how we're collecting information about patients and how we're storing that and sharing it. So the next team is our person and whānau-centred team, and Fletcher Beasley is our manager of this team. So the perspectives, and this team is really critical actually for the work that Te Ahu Takahu flows out, and it does feed in and guide a lot of what we do. So in recognition that the perspectives of people affected by cancer is critical component for driving change. And so this also reflects Te Ahu Takahu's active embracing of the perspectives of patients and whānau and caregivers affected by cancer. So from February to July of this year, Fletcher and his team travelled across the country to listen and learn from whānau Māori about their experience of the cancer system in Aotearoa. There were 50 Māori community Cancerhui held from Kaikohe to Invercargill. Now his team made sure that everyone who attended the hui, which was well over 2,000, were made welcome and treated with respect and were heard. It was also a really amazing opportunity for healthcare providers, non-government organisations and members of the health sector to also come and join. And we were really privileged to have leukemia and blood cancer attend many of these hui to be able to provide support for whānau on their cancer journey, but also lots of really great information on the spot as well. So the stories which flowed from these sessions will provide invaluable insights into how our health system can be improved for Māori and for all actually for a long time. And another important element of the hui was bringing together parts of the sector to display how they can support people with cancer. And once again, this reflects the weaving together of people demonstrated by our name, Te Ahu Takahu. So there was I just wanted to read out one of the feedback emails that we received from a participant at the Cancerhui, because it really did sum up how the overall impact that these hui were having within the community. So just a quick excerpt. So on behalf of Te Hauora o Ngāpuhi, we'd just like to say a big thank you for the Māori Cancerhui and Kaikohe and for all that you're doing in the community. Yesterday's experience really touched my heart to hear the reality of the challenges that many people with cancer are living with every day. Although we do not have all of these solutions, it was great to see the way local, regional and national health service providers are working collaboratively to offer hope, support and services to address some of these challenges. With your support, the event brought a queer kaumātua voice to the future design of cancer services in Aotearoa. This uplifted our spirits and well-being and enabled all of our kaumātua in the hui to leave feeling confident that change is abreast. So the last team member that we have is prioritisation, innovation and research, and this really talks to our access. This is a team that's overseeing access to clinical trials and strengthening approaches to molecular testing in New Zealand. So the manager is Nisha Nia, and the great thing about this team is that they're really interested in innovation. So I was really excited to hear about in your presentation, Rob, about umbrella trials and the approach of adapted trial design. That is definitely an exciting area and extremely necessary in these times to ensure that we're getting more readily available results from cancer trials and allowing that flexibility within trials. So Nisha has been involved in scoping the sorts of cancer trials that are currently underway in Aotearoa, New Zealand. With regards to strengthening our approach to molecular testing in New Zealand, this is in the context of, and you touched on this briefly, Rob, as molecular testing or genomic testing in New Zealand can be used to detect changes either within cancer cells or within a person's DNA. So this can help confirm a diagnosis, but it can also predict the aggressiveness of the cancer and predict the likelihood that the cancer will respond to certain drugs. It can also identify a syndrome that predisposes a person or the whānau to additional cancers. So currently within the system nationally, there's inconsistencies in access to molecular testing for patients, and this can be a significant challenge. So some patients in DHBs may have easy access to a particular test, whereas patients in other DHBs may have limited access or be required to fund the test themselves. So work is underway currently to look at addressing these inconsistencies. So just mindful of the time, Te Ahu Takahu is also involved in many other work streams. A lot of the work that we're currently looking at is looking at services and how we can best structure services moving into the new health reform environment to ensure that services remain or are coordinated and streamlined and are patient and whānau centred. Another piece of work that Te Ahu Takahu has been involved in since COVID, since we first had our COVID lockdown during Alert Level 4 last year, was to stand up a cancer agency agile response team. And this team worked to, sorry, I've skipped a page, but this team basically worked to ensure that nationally cancer services, including diagnostic services and treatment, were going to remain open for patients for as long as they could, and not to knee-jerk response to the Alert Level 4 lockdown that we saw lots of other services nationally doing. And so as a result of the Agile Response Team meeting from within Te Ahu Takahu, the working group, so the haematology working group, was involved in informing guidelines to help hospitals navigate the alert level space and to ensure that patients and whānau still had access to services in a safe and appropriate way. Those cancer guidelines were rolled out, was stood up recently again during this current COVID lockdown, and they have been really successful in ensuring that the DHBs and cancer services had a guideline to at least guide whether or not they were going to limit or restrict services based on the alert level that the DHB was currently sitting in. There's another within the COVID space, and I won't talk to this too long because there's another session coming, but Te Ahu Takahu met with the Agile Response Team and with the working groups, the clinical working groups, including the haematology working groups, to confirm what the vaccination advice would be for haematology patients around their times of treatment. So that was an important piece of work that was carried out by the KAKAT, or the Agile team, just recently. One last point that I'll quickly touch on is that supporting DHBs is another key role that Te Ahu Takahu plays. And it was most recently seen with the cybersecurity incident at Waikato DHB, where the IT systems created a really challenging situation for those being treated for cancer, for those delivering cancer services, but also for patients and whānau coming through the services and being treated for cancer. And our Waikato medical oncology, haematology and radiation oncology services. So Te Ahu Takahu played a significant role in being able to offer support by escalating this as a national risk due to loss of capacity for cancer service delivery. For radiation oncology patients, treatment was outsourced to Auckland Hospital, Tauranga or Wellington hospitals. And Jan Smith and the team from Te Manuataki worked really hard alongside the DHB to provide critical data and records that were so essential for treatment during this time. So the ability to provide local and regional support is where the Te Manuataki and regional hub structure really came into its own. So finally, there's, and I'll just wrap up because I'm moving into the extent of my time, but there are other activities that Te Kahu is involved in, including interface with the National Cancer Registry, the Cancer Prevention and the NSU, Health Workforce Directorate and the Ministry of Health, Pharmac as well, building relationship with Pharmac and recognition of how important that relationship is to ensure that we can advocate for all of the needs and feedback that we get from the different leadership and advisory groups that feed into Te Kahu. So the future rather than the end, what does the future look like, particularly in the context of the health reforms on the horizon? So Te Kahu will continue as a departmental agency working alongside the new entities. Te Kahu is well placed to adapt to and add value to the changes on the horizon as well. A key focus for us is to ensure that the current services are not disrupted by the reform process, and as time goes on and as more details come to the fore, we'll be able to see how we will need to adapt in the new environment coming forward. But for us, our main focus stays the same, that improving cancer outcomes for all patients and whānau in Aotearoa is our key goal. So nera te mihi kia koutou katoa. I hope you all stay well, and also want to mihi to all of those who are dialing in from Auckland. We're all thinking of you during your extended lockdown period. So kia ora.
Oh, kia ora, Dr. Myra, thank you. Look, I like that, the central thread that binds us all. Thank you for providing such a great overview of the agency and how it's working for us all to bring equity-led, knowledge-driven and strong leadership to preventing and managing cancer in Aotearoa.